Thank you, Naren. So good afternoon from Brazil for everyone. I think that in a brief time, you can see more dinners together after the pandemic situation. So also again, thank you for the kind invitation. And before to starting, Naren, you have a hard and excellent working to promote in neurosurgery, pediatric neurosurgery around the world. So it's my pleasure to be here again, talk with this topic. So thank you so much for the kind invitation.
Thank you.
First of all, just an overview of the main topics that we will discuss now. So Naren told me to summarize in my presentation these topics. So I will step by step talking about each one of these points. Just some highlights. So it is important. The phylum terminal is a fibrous collagenous band that normally stands from the conus through the subarachnoid space to pierce the dura and its caudal terminus in the sacral and therefore become anchored to the coccyx. But we know that from embryology, probably the phylum terminal is an embryological regression of a spinal cord. So it's a normal situation that occurs with us during our embryological life, and the phylum terminal, it's only a regression of the spinal cord. So naturally, it's very thin, and when it gets thick with sometimes fat tissue, it can cause the tetraspine cord syndrome. That was first published on literature in 1976 by the Canadian group, by the Hoffman, Hendrick, and reported improvement of symptoms after sectioning of thickening phylum terminal in 32 patients with neurological deficits of the lower extremities and incontinence. So we have two kinds of patients, two kinds of symptoms. We have, in one way, we can see asymptomatic or incidental patients. And in the other way, you can see the tetracord syndrome that resulting tension causes symptoms such as bladder and bowel incontinence and weakness of the legs. And sometimes you can see over the skin some cutaneous anomalies that is very common on the acute dysarthrism, and it can be a clue. From the pathology, just some words about the pathology. It's important to understand that the phylum terminal, when it's an abnormal retrogressive differentiation with inclusion of mesoderm in the phylum terminal, as for instance, adipose tissue, elastic fibers, vascular lacunes, nervous or muscle tissues, or inflammatory cells, you can see the situation, the physiopathology of the phylum terminal that can become thick and cause or initiate some symptoms. In this table, I divided the clinical presentation in three main points. From the first ones, the urinary, the motor, and the pain. And in this part, according to the age, you can see some red flags. It means that for instance, from infants, the motor is the predominance, so lower extremity or spinal deformities. For the toddlers, the urinary problems, even from incontinence or abnormalities in aerodynamic testing. So it's a red flags for toddlers. Older children, the predominance are motor, again, through sensory loss or progressive scoliosis, or in some cases spasticity. And in adults, the pain is the most predominant, so back pain, or in some case after trauma. You can see here in adults and in some as well in older children an acute appearance of symptoms. So this is important, these red flags according to the age. When you see a patient with diagnosis of tetrachord syndrome, these are the main points that you can investigate. First of all, the clinical and the neurological examination. So to present in some cases, as I said, cutaneous anomalies, it's important to see hyperreflexy, sensibility, or some deformity as scoliosis. The gold standard in terms of radiological findings is the MRI. The main characteristic, the main findings, as in T1 is hyper intense, the phylum terminal. The T2 is hyper intense. The fat saturate sequence is very important, and you can see signal loss that can be demonstrated. And after gadolinium administration, generally, you don't see any or no enhancement. It's very nice. You need to take in mind the fat film thicker than 2 millimeters are regarded as filar lipomas. So as you can see here in these images, the typical fat film, as you can see here, so greater than 2 millimeters. And about the urodynamic studies is very important in older children and of course in adults. Just a word about ultrasound. Ultrasound is a very nice screening exam that you can perform in neonates, or when you have some doubts in terms of when you can see just a skin abnormality, but you're not sure, or it's a very young children. So ultrasound can be used to identify the position of the conus as well the position of the phylum terminal. And it's good to remember the normal ultrasound, as you can see here on the left, is the maximum thickness of the phylum terminal was about 0.6 millimeters. And in this part that you can compare with an MRI on the right side, so you can see a fat phylum, and comparing with the ultrasound, it's very similar image. So about the surgery, there are classical indications for surgery when you see symptomatic patients who have unequivocally low-lying conus that you can see on MRI with an abnormal appearance of the phylum on image. And in another point, you have some contraindication or relative contraindication when you see a normal position conus with or without a fat or thickened phylum may provide challenges and make decision to indicate a surgery. Or when you see incidental or asymptomatic patients. About the surgery, so I divided this first slide in 4 main steps. So this is important, this is the key highlights for you. So first one, surgery for thickness phylum terminal syndrome should be performed via midline, generally it's a midline incision between L4 and L5 or L5 and S1 spinal process. The dura mater and the arachnoid mater should be cut open in the phylum terminal identify according to the midline location. The final terminal should be separated from the roots and slightly rotated to identify the presence of some nerve adhesion on the ventral side. So after electrocoagulation, 5 millimeters, about 5 millimeters of phylum terminal should be cut off as a specimen for pathological evaluation. Now we can see step by step the surgery. The initial point is to discuss with the anesthesiologist what we will do, and it is important to discuss with the anesthesiologist. If you decided to monitoring the patient, it's important to discuss a short-acting muscle relaxing during induction to allow for intraoperative stimulation of nerve roots. The position, generally, we use the ventral position using some chest rolls to improve the venous outflow. The catheterization, the urinary catheterization, it's important during the surgery as well after surgery. Midline lumbar incision, or if you have abnormal or some cutaneous abnormality, you can use some elliptical fashion, thus excision skin dimple. So after the midline, dissected down to the lamina beware spina bifida occulta in some case. And about approach, intradural, and procedure. For young kids, I usually use a craniotomy, the foot plate, to do the laminotomies in one block. So I cut the both sides of the spinal process, and laminotomy standard laterally with a round joint, a Kaizen round joint, we need reflect entire block still attached proximally to intact vertebra, proximally. For older kids, normal laminectomy, or in some cases laminotomies, to widen interspace. And it is very important to control epidural venous bleeding with the bipolar cautery, or in some case putting some sponge or some hemostates. Why? Because it's important to avoiding arachnoiditis or scar in the thecal sac after surgery. It's in meticulous stepwise fashion, open thecal sac longitudinally in midline using a 50 blade, and it's important the Duratec knop using 4-0 silks. After fine fillum, dissect away nerve roots, stimulation using bipolar probe fork, coagulate and transect the phylum below the point where no electromyogram response are obtainable. If activates only anal sphincter, it is okay to cut. This illustration represents the two main approach to cut the phylum. You can use an interlaminar approach, or to obtain more space using the laminoplasty, retracting in the proximal part the lamina, and to have more space to do the surgery. These are some pictures looking intradurally how looks like a fat phylum. So you can see here, before to dissecate the roots, after protecting the phylum that you starting cut, and then to cut part of the phylum and to send to the pathologist. And this part of the illustration, you can see here how important it is to dissecate anteriorly and laterally all the nerves, all the roots involving the phylum terminal before to decide to cut. And in this part, you can see the classical fat phylum, the terminal fat phylum. About the closure and postoperative care, So it's important during the surgery, irrigation constantly the subdural space to avoiding clots and hemorrhage to prevent scars. Durotomy closed, you need to be obsessive with the durotomy and the watertight with simple running 5-0 pro-lane suture. And you can use fibrin glue to reinforce your line. It's important before, when you finish the closure, the dura, to ask for the anesthesiologist to take intradurally to Valsalva to check if you have some points to CSF. Laminoplasty, if you use laminoplasty, block of the lamina in spinous process, replacing and fix back in place with suture, generally reabsorbable suture. No drain, 4-0 simple running monocrystal or nylon suture for skin, or in the postoperative, the children need to be flat for 1-3 days on PICU. This is a clinical case. It's a 9-year-old male. So you can see here the classical fat filum. So the anchor, the thickness of the filum terminal in a child that presented the tetrad cord syndrome. So in this part, you can see here the T1 after contrast, the adipose tissue involving the fat, the filum, and in T2, the hyperintensity in T2. This is a video that you can see here, the main steps. So this is the before to open the dura, so a distal approach. So I usually do this surgery under microscopy over the starting, even for the closure, the dura. So using the microscope, open the dura carefully with the hemostasis using bipolar or some hemostatic agent to prevent bleeding. So after starting to exposing the filum, dissecate all the roots laterally and also anteriorly to isolate completely the filum, and then some sutures to anchor the dura to facilitate the surgery. So you can see here some adipose tissue involving the filum. So liberate all the adhesions on laterally. And then when you are absolutely sure that the filum is completely free of the roots, starting coagulating, and then cut the filum. It's interesting, at the moment that we cut the final part of the filum, how the filum coming up immediately after cutting the final part of the filum. You can see here how the filum coming up after completely free. Irrigated to prevent any kind of bleeding, and then starting closer, it's a running suture under microscope to check if there is no space to have a CSF leak on the postoperative. So it's important, this part it's very important to stay on the microscope until the end of the surgery. Just one word about a difficult case. Some years ago, in 2000, around 2000, they described the acute tetrad cord syndrome. So you can see a normal image in those patients, but they presented with classical, clinical of tetrad cord syndrome. So it's important in this group of the patient to look for some specific problems. For instance, the Ehlers-Danlos syndrome that can be associated with this kind of situation. So in some cases, it's not easy to have the diagnosis of the film, the thick film, and you need to decide to do a surgery by clinical and in some cases urinary investigation of these children. So complication, pitfalls, prognosis, and bowel. So it's the main step is the correct identification of the film before to cut, to prevent and to be obsessive with the closure to prevent CSF leak. In some cases, it's important not to add any kind of neurological deficit and to prevent retethering. For instance, using irrigation during the surgery and to check if the film was completely detached. And children may develop some difficulty with urinary, and they can require intermittent catheterization because of the manipulation of the lower nerve roots after surgery. And in this case, it's important to stay with the follow catheter for 2-3 days after surgery to be sure that the children did not develop urinary problems after surgery. It is generally felt that sectioning of symptomatic film is a curative surgery. An orthopedic and motor deficit should be stabilized and sensory symptoms are likely to resolve. And however, follow-up MRI imaging will always demonstrate a low lining canals, and in the absence of clinical history will be interpreted by the radiologist as showing a tethered spinal cord. So because of this, it's important to talk with the radiologist and try to explain the surgery that was done, and in some cases, the low lining canals stay below, and it's important to discuss with the radiologist to think in the same way and to have the same reported to the family. So I would like to finish my presentation, invite you to participate in October 17. We'll have a neuroendoscopy, a day on the neuroendoscopy with some international faculties around the world, so promoting by the Brazilian Pediatric Neurosurgery Society. So you are invited to participate with us. Thank you, Neri, again for this kind invitation.
Thank you very much, Professor De Oliveira. You have covered the topic very systematically, and as I am having a hard time that you find any questions because you have covered everything so well. I think Dr. Alan Foster from Aberdeen, he's an eminent neurophysiologist. In UK that we use neurophysiology, even for untethering. And his question is, do you stimulate before sectioning? Often some sacral nerve fibers can be hidden at the back of the phylum. I have the first question to you, then I'll ask a question to Dr. Foster. Thanks.
Yes, Ari, it's a very nice, very good question. Yes, today, in some papers, when you analyze the literature about this kind of surgery, there are some authors that they usually did not use the monitoring during the sectioning of the phylum. But in my practice, I usually use the monitoring before to cut the phylum. I isolate the phylum, I dissect all the roots, and before to cut, I stimulate the phylum. And if it's okay, I cut the phylum. But I think that it's important for two reasons: to protect yourself and for the medical legal reason.
That's great. If I can ask Dr. Foster question, in terms of, is there evidence that actually checking, apart from the medical legal side, actually it does make a difference? If you can't actually discern it with the eye, is the fibers too small to be actually of any significance?
Well, yeah. I'm sure all surgeons have perfect eyesight, but certainly in Aberdeen, when stimulating in adults, no, there's nothing here. Stimulation, clear twitch in the sphincter, and then they look a bit closer, and they see that in fact there were some fibers. I wonder if that's the reason in the literature for some of the urological problems afterwards, because you could record obviously from urethral. We tend to only record from anal sphincter. Some do bulbocavenosus reflex at the same time as well, but most people just stick needles in the anal sphincter.
That's great. Thanks.
There are now electrodes so you can record from urethral as well if you wish to.
Oh, wow.
And that probably would be a sensible thing to do. But certainly double checking, as you say, legally. And I don't think all surgeons see everything all the time.
I think that you make a great point. And Professor Oliveira, thank you, Dr. Foster. Professor Oliveira, do you have any comments?
No, it's okay. Great.
Thank you.
Great course.
And there's a few questions for you. Let me see. Yeah, I think you have answered them. And does it matter at what level that you disconnect, do the disconnection, low down or higher up in the theca, in the lumbar level?
Yes, I prefer to disconnect caudally, more caudally. Yeah.
That's great. That's brilliant. And certainly the occult spinal cord tethering, thanks for touching on that. It's a area that I have got a patient currently who I'm trying to figure out whether it's occult spinal cord tethering or some other syndrome. Let me see. Great. Thank you very much, Professor De Oliveira.